Most people over 60 believe that if a medication is prescribed by a doctor, it is safe. And if a medication is sold over the counter at a pharmacy without a prescription, available to anyone, sitting on an open shelf, it is even safer. So taking both at the same time? Perfectly fine. Right? That assumption is quietly killing people. And I do not use that phrase loosely or for effect. I use it because I have stood at the bedsides of patients whose outcomes were directly and preventably determined by a combination of two pills, one prescribed, one purchased without a second thought at a drugstore, that their doctors never explicitly warned them not to take together. Not because their doctors were negligent, but because this conversation, this specific, critical, life-determining conversation about what happens when certain medications combine inside a body over 60, is one of the most consistently skipped discussions in modern primary care. Today we are having that conversation. All of it in full. I'm Dr. Ryan Foster. I'm a cardiologist with more than 2 decades of clinical experience treating cardiovascular disease in adults, and a significant portion of that experience has been spent in exactly the territory we are entering today, polypharmacy. The clinical term for taking multiple medications simultaneously is one of the defining and most dangerous characteristics of healthcare after 60. The average adult over 65 in the United States takes between 5 and 7 prescription medications daily. Add over-the-counter drugs, herbal supplements, and vitamins, and that number climbs significantly higher. Each of those substances has its own mechanism, its own pathway through your liver, your kidneys, your bloodstream, its own effect on your heart rate, your vessel walls, your clotting system. And when certain combinations meet inside a body whose metabolism has slowed, whose kidney function has declined, whose liver processes drugs more slowly than it did at 40, the interaction is not simply additive. It can be multiplicative. It can be catastrophic. And it can happen with combinations so common, so ordinary, so routinely used by millions of seniors that most people reading the labels would never in their lives suspect a danger. I have seen this, not in textbooks, in my patients, in people who trusted the system and were let down by a gap in that system that you are going to understand completely by the end of this video. Here is the core problem with how medication safety is understood or catastrophically misunderstood by the majority of adults over 60. When your cardiologist prescribes a blood pressure medication, they are focused on that medication's effect on your cardiovascular system. When your orthopedic doctor recommends something for your knee pain, they are focused on your knee. When you pick up something from a pharmacy shelf for a headache, nobody in that interaction is thinking about what is already in your medicine cabinet. This is called the prescribing silo problem. Each physician sees their piece of your health. Almost nobody is seeing all of it simultaneously and specifically. Almost nobody is actively managing the interaction between the medications you receive from different hands. After 60, your body's ability to handle this chemical complexity is genuinely diminished. Your kidney filtration rate, the speed at which your kidneys clear drugs from your system, declines by approximately 1% every year after the age of 40. Your liver's enzyme activity, the system responsible for metabolizing most drugs, slows measurably. What this means clinically is that a drug interaction that might produce a mild, temporary, self-resolving effect in a 35-year-old can produce a prolonged, severe, organ-damaging, and potentially fatal outcome in a 70-year-old using the exact same 2 medications at the exact same doses. The drugs did not become more dangerous. The body processing them became less forgiving. And the 2 categories of medication involved in the combination I am about to discuss are taken together by millions of seniors every single day. The combination I want to focus your attention on today is one of the most clinically significant and most underappreciated in senior cardiovascular care. It is the combination of blood thinners, specifically anticoagulants, like warfarin, or newer agents like rivaroxaban and apixaban, combined with common over-the-counter non-steroidal anti-inflammatory drugs, NSAIDs. The category that includes ibuprofen, naproxen, and dozens of branded pain relievers sitting on pharmacy shelves, available without a prescription, marketed for headaches, joint pain, muscle aches, and arthritis. Here is what happens physiologically when these 2 substances combine inside a body over 60 and it is critical that you understand each mechanism separately before understanding what they produce together. Anticoagulants work by interfering with your blood's clotting, cascade the sequence of chemical steps your body uses to form a protective clot when a vessel is damaged. This is intentional and necessary. Millions of seniors take anticoagulants to prevent stroke, to manage atrial fibrillation, to protect artificial heart valves. The medication is doing its designed job. NSAIDs work through a completely different but equally significant mechanism. They inhibit the enzymes, specifically COX-1 and COX-2, that your stomach lining uses to produce its protective mucus layer. Without that mucus layer, the stomach wall is directly exposed to gastric acid. In a healthy younger person, this effect is temporary, and the stomach recovers quickly. In a person over 60, whose gastric lining is already thinner, whose stomach's regenerative capacity has declined, and whose kidneys clear drugs more slowly, that exposure is prolonged. Microscopic erosions form. Small bleeds begin in the gastrointestinal wall. Now combine the two. An anticoagulant that has deliberately reduced your blood's ability to clot. A gastrointestinal wall with microscopic bleeds that cannot stop because the clotting capacity has been pharmacologically suppressed. The result is gastrointestinal hemorrhage, internal bleeding, that can progress from invisible to catastrophic before a single external symptom appears. And simultaneously, NSAIDs interfere with kidney blood flow, causing sodium and fluid retention that directly antagonizes the blood pressure control your cardiologist has carefully calibrated. Blood pressure rises. The anticoagulant's concentration in the bloodstream shifts unpredictably. The therapeutic window, the narrow range in which the blood thinner is effective without being dangerous, is disrupted. 2 pills, millions of people taking them together. Right now, tonight, not knowing. Let me give you a real clinical example. A patient, 74 years old, retired, history of atrial fibrillation, managed well, on anticoagulation therapy for 3 years without incident. His INR, the measure of how thinned his blood is, had been stable and within the therapeutic range for 18 consecutive months. His cardiologist was satisfied. He was satisfied. He develops knee pain in the winter, not unusual, very common after 60. His neighbor recommends ibuprofen. He picks up a standard over-the-counter package. The label says suitable for adults. He is an adult. He takes it. He tells nobody. He does not consider it a medication in the same category as his prescription. It is something you buy at a drugstore. It does not require a doctor's signature. How significant could it be? 4 days later, his wife calls an ambulance. He is pale, dizzy, confused, and has passed stool that is black and tarry, the clinical presentation of significant upper gastrointestinal bleeding. His hemoglobin on arrival at the emergency department is critically low. His INR has shifted dramatically outside its therapeutic range. He requires hospitalization, blood transfusion, and temporary suspension of his anticoagulation, which itself carries its own stroke risk. The entire cascade began with ibuprofen, an over-the-counter anti-inflammatory he did not consider significant enough to mention to his doctor. He survived. Not every patient in this situation does. And when I sat with him afterward and asked whether he knew about the interaction, whether anyone had ever explicitly told him that NSAIDs and anticoagulants should not be combined, he looked at me with complete sincerity and said, "Nobody ever told me that." He was not reckless. He was not careless. He was simply operating on incomplete information in a system that left a critical gap between his prescriptions. We have a clinical term for this phenomenon: drug-drug interactions, specifically pharmacokinetic and pharmacodynamic interactions that produce outcomes more severe than either drug would produce individually. And the numbers surrounding this specific combination are striking. Research consistently shows that adults taking anticoagulants who are concurrently exposed to NSAIDs face a risk of serious gastrointestinal bleeding that is 3 to 4 times higher than those on anticoagulants alone. 3 to 4 times higher. From a drug available without a prescription. Among adults over 65, studies estimate that between 20 and 30% of those on long-term anticoagulation therapy use NSAIDs concurrently, in many cases without informing their prescribing physician. Nearly 1 in 3 seniors on blood thinners, A major analysis examining medication-related hospital admissions in adults over 65 found that drug interactions were responsible for approximately 30% of all medication-related hospitalizations in this age group. Nearly one-third. Not rare, not exceptional, nearly 1 in 3. And this specific combination, anticoagulants and NSAIDs, consistently appears among the top 5 most dangerous drug interactions identified in hospital admission data for seniors year after year across multiple countries and healthcare systems. Most of those admissions were preventable. Most of those patients had never been explicitly warned. Not once. Not by anyone. Standard prescription discussions almost never include over-the-counter interaction warnings. And that is exactly why this video exists. Now let me tell you about 3 things already in the medicine cabinets and daily habits of most adults over 60 that are silently compounding this risk every single day. At least one of these applies directly to your life. The first is aspirin, specifically low-dose daily aspirin combined with anticoagulants. Many seniors have been taking low-dose aspirin, 81 milligrams, for years, often since a doctor recommended it for heart protection during a different era of cardiovascular guidelines. Current guidelines have significantly revised that recommendation. Low-dose aspirin is no longer routinely recommended for primary prevention in adults over 60, but the combination of aspirin and an anticoagulant, even low-dose aspirin, doubles the bleeding risk compared to the anticoagulant alone. 2 blood-thinning mechanisms operating simultaneously, when one was intended as a supplement and the other as a prescription. Check your daily pill organizer tonight. If aspirin is in there alongside a blood thinner, that conversation with your doctor is urgent. Not eventually, urgent. The second is common herbal supplements, specifically fish oil, vitamin E, and ginkgo biloba. Each of these has documented antiplatelet activity, meaning they inhibit platelet clumping, which is part of the normal clotting process. Individually, in healthy adults, these effects are modest. Combined with pharmaceutical anticoagulation, they add an additional layer of bleeding risk that most patients never disclose because they do not consider supplements to be medications. They are natural. They come from a health food store. Your liver does not distinguish between a synthetic compound and a plant-derived one. It processes both. And the combined anticoagulant effect of warfarin plus fish oil plus ginkgo biloba can shift your INR to dangerous levels without a single prescription change. Tell your cardiologist everything that goes into your mouth on a daily basis. Every supplement, every herbal tea, every vitamin. That list is a clinical document. The third is naproxen, specifically the perception that naproxen is safer than ibuprofen. Many seniors switch from ibuprofen to naproxen, believing it carries lower cardiovascular risk. There is some evidence supporting reduced cardiovascular risk from naproxen compared to other NSAIDs. There is no meaningful evidence that naproxen carries lower gastrointestinal bleeding risk when combined with anticoagulants. The KOX1 inhibition. The mechanism that strips the stomach's protective lining is present in naproxen with the same clinical significance as in ibuprofen. The perceived safety of naproxen has led many seniors on blood thinners to use it without concern. That perception, in this specific context, is clinically incorrect and potentially life-threatening. 3 specific actions you can bring to your next medical appointment. Write these down before this video ends. The first is a complete medication reconciliation review, specifically including all over-the-counter drugs, supplements, and herbal products. Request this by name. Ask your doctor or pharmacist to conduct a formal interaction review of every substance you take, prescribed and otherwise. Most practices do not perform this routinely unless you specifically initiate it. This review has the potential to identify interactions that have been silently present for months or years. The second is an INR stability review if you are on warfarin specifically. Ask your doctor to review your INR history for unexplained fluctuations over the past 12 months. Inconsistent INR values that do not correspond to diet changes frequently indicate an unidentified interacting substance. This pattern, when reviewed in context, can reveal interactions that were present but never identified as such. If you are on one of the newer anticoagulants, rivaroxaban, apixaban, or dabigatran, ask specifically about kidney function monitoring. These drugs are cleared renally and declining kidney function in seniors can cause their effective concentration to rise silently, increasing bleeding risk without any dose change. The third is a pharmacist medication therapy management session. This is a dedicated one-on-one appointment with a clinical pharmacist separate from a prescription pickup, specifically designed to review your complete medication list for interactions, duplications, and safety concerns. It is available at most major pharmacies. It is frequently covered by Medicare Part D. It is almost never proactively offered. Requested by name. Medication therapy management, MTM. 3 items. Medication reconciliation review. INR stability review or renal function monitoring. Medication therapy management session. Write them down. Fold the paper. Put it next to your prescription bottles tonight. Practical step. Beginning with the most important one you can take in the next 24 hours. Create your complete medication list tonight. Every single substance. Not just your prescriptions. Every over-the-counter tablet, every supplement capsule, every vitamin bottle, every herbal tea consumed regularly. Write the name, the dose, and the time of day you take it. That list is one of the most clinically powerful documents you can bring to any medical appointment. Physicians make better decisions with complete information. Most physicians are making decisions with incomplete information because most patients do not think to bring the full picture. Your list changes that. Establish a single pharmacist relationship. If you fill prescriptions at multiple pharmacies, a common situation when different doctors send prescriptions to different locations, your complete medication profile does not exist in any single system. No pharmacy can flag an interaction they cannot see. Consolidating your prescriptions at one pharmacy, where your complete profile is visible, allows their interaction checking software to function as it was designed. This single logistical change has been shown in research to meaningfully reduce the rate of undetected drug interactions in senior patients. For pain management specifically, have the acetaminophen conversation. If you're on anticoagulation therapy and you use pain relievers regularly for arthritis, joint pain, or headaches, ask your doctor whether acetaminophen at appropriate doses represents a safer alternative for your specific situation. Acetaminophen does not carry the COX-1 inhibition of NSAIDs. It does not strip the gastric lining. It does not interact with anticoagulants through the same dangerous mechanisms. It has its own considerations at high doses, specifically liver function, but for many seniors on blood thinners, it represents a meaningfully safer pain management option that is almost never proactively discussed. Ask the question. One specific question at one appointment could replace a dangerous daily habit with a safer alternative permanently. I want to tell you something directly, something I think about consistently in the context of what we've discussed today. The patient I described earlier, the man with the gastrointestinal bleed, was not failed by medicine. He was failed by a gap in medicine. A communication gap, a systems gap, a gap between what was prescribed, what was purchased, and what was known by anyone responsible for the whole picture. He went to his cardiologist for his heart. He went to his primary care physician for his general health. He went to a drugstore for his knee pain. None of those interactions produced the conversation that could have prevented what happened. I have seen versions of that story more times than I want to count. And every single time the patient did not know. Not because they were careless, because nobody told them. Because the system assumed somebody else was having that conversation. You have every right to demand that conversation. You have every right to walk into your next appointment with a complete medication list and say, I need a formal interaction review of everything on this list. You are not being difficult. You are not being paranoid. You are being the one person in your healthcare system who is looking at the whole picture at the same time. Because nobody else is doing it for you. Not because they do not care. Because the system is not built for it. You have to build it yourself. And now you know exactly how. Let me bring everything together with complete clarity. After 60, the body's ability to process multiple medications simultaneously is genuinely and measurably diminished. Slower kidney clearance, slower liver metabolism, thinner gastric lining, narrower therapeutic windows. The combination of anticoagulants and NSAIDs, blood thinners, and common over-the-counter pain relievers represents one of the most dangerous and most common drug interactions in senior health care. 3 to 4 times higher bleeding risk. Nearly 1 in 3 seniors on anticoagulants exposed. consistently among the top 5 dangerous interactions in hospital admission data for adults over 65. 3 hidden risks already in your daily routine may be compounding this danger right now. Low-dose aspirin combined with anticoagulants, herbal supplements with antiplatelet activity, and the false safety perception of naproxen. 3 clinical actions will close the gap: a formal medication reconciliation review, an INR stability or renal function review, and a medication therapy management session with a clinical pharmacist. Your 3 actions beginning tonight: 1. Write your complete medication list. Every prescription, every supplement, every over-the-counter tablet, every herbal tea. Tonight, before you go to sleep. 2. Look at that list and identify every pain reliever. If any NSAID, ibuprofen, naproxen, aspirin appears alongside an anticoagulant, mark it. That mark is the most important agenda item for your next medical appointment. 3. Bring that list to your doctor and request, by name, formal medication interaction review, INR stability review or renal function check, medication therapy management session. Has your doctor ever reviewed your complete medication list, including supplements and over-the-counter drugs, in a single appointment? Have you ever been specifically warned about NSAID interactions? Tell me in the comments below. I read every single one. Your experience genuinely helps others in this community understand what questions they need to ask. If this video gave you something meaningful today, please share it with one person over 60 in your life who takes a blood thinner, who takes daily aspirin, or who reaches for ibuprofen without a second thought. This is precisely the kind of information that falls between appointments and between prescriptions. Your share could prevent something irreversible. Subscribe to Dr. Ryan Foster for evidence-based cardiovascular content built specifically for adults navigating healthcare after 60. There is much more critical ground to cover. We are just getting started. One final thing, and I want to be completely direct. Everything in this video reflects current pharmacological research and my clinical experience in cardiovascular medicine. It is educational information, not personal medical advice. Your medication situation is individual. Your kidney function, your liver health, your specific drug regimen, all of these require direct evaluation by your own physician. Do not stop any prescribed medication because of this video. Do not make any changes to your medication routine without speaking directly to your doctor or pharmacist first. The goal of this video is to equip you for a better, more specific, more informed conversation with your healthcare team, not to replace that conversation. If you experience unusual bruising, black or tarry stools, blood in your urine, sudden severe headache, or any unusual bleeding, seek medical attention immediately. Do not wait. Your heart, your blood, your vessels, they have worked faithfully for every decade of your life. Give them the protection of complete information. Walk into your next appointment with your list. Walk in knowing exactly what to ask. That conversation, that one specific, informed, prepared conversation changes everything. I will see you in the next video. Until then, take exceptional care of yourself and of everyone you love.